Katie gives me the finger. I don't want to hold up my finger to be live onto YouTube. Thank you. Thank you, Katie. Welcome back to Labor and Health afternoon. If you have an agenda in your hands, throw it away because we're going to change it. So we have an awful lot of people here to talk about the behavioral health. We're going to jump straight to behavioral health, which would be item 6 on your agenda. We'll see how long that takes. We have a hard stop at 3:15. End of story. There's no question about that. 3:15 we end. We're going to WBI for a tour of the committee members. If we have time, if we get through this behavioral health stuff quick enough, we might throw one of those other things on or a piece of them if we do. That being the impetus to talk fast. We want to cover everything and we want all the testimony, certainly. We don't want to just skip anything. It's too important to do that. But that's the plan. So we're going to go straight to behavioral health. Item number 6, Wyoming Department of Health. Welcome back, gentlemen.
Mr. Chairman, members of the committee, again, Stephen Johansson with the Department of Health. I'll be brief with the behavioral health topic. This is primarily around Senate Enrolled Act 56, I believe was the number, House Enrolled Act 56, House Bill 38. That bill passed in the previous session, directing the Department of Health to begin implementation of a broader community behavioral health reform effort. Accordingly, over the summer, we worked with a provider stakeholder group, held public meetings, and I'll have Franz give an update on some of that and also go through the report that this committee received, I believe on September 1st. We'll just say, Mr. Chairman and members of the committee, very pleased and grateful for the work that has gone on this first phase of this reform implementation, both from the state staff as well as the provider group who has worked with us. These are not easy topics. It's difficult to get consensus sometimes, but I think we're really on the right track to implement something that will benefit this state greatly in the behavioral health area. Part of the report went over what we did over the summer as required by the legislation. And the real meat of that report was really the recommendations from the steering committee that was established, including legislators, executive branch directors, that has some legislative recommendations for sort of the next phase of this reform effort. So with that, I'll have Franz go over the information in the report. I'm not sure if we have Representative Larson on Zoom. I believe he was planning to join, but maybe got detached during some of the morning delays. So Franz, take it away.
Thank you. Good afternoon, Mr. Chairman, Madam Co-Chair, members of the committee. Again, my name is Franz Fuchs. I'm a policy analyst at the Department of Health. And as Director Johansson indicated, we spent the summer kind of going through this reform process. It's a very, very complex issue, as we'll kind of talk about. And so we did not, unfortunately, get to address, as you know, every single aspect that was demanded or required in House Bill 38. So part of this bill that we'll go through, or the suggested bill, we'll be suggesting delaying the implementation, kicking it back a year. So we'll get to that. But I just want to indicate that up front that we were unable to sort of check every box, although we did put a lot of time and a lot of effort with significant contributions from our stakeholder groups and legislators, as you well know. So with this report that we sent, I was just going to go through hit the highlights, talk about a little bit of background on the current system, kind of talk about the problems that we're trying to solve with this. That's really the first question we need to be asking is, what is the problem you're trying to solve with any given solution?
To go to your mailbox.
Yeah.
If you go back to your mailbox, you can find it online, actually, at one of your presentations that you've got. Okay, let's go ahead and proceed. Okay, go ahead.
So, Mr. Chairman, yeah, I should have probably talked about what I was presenting on the screen here. I was going to skip the history section. I'm going to start with the current background to kind of talk about the current system as is, move on to sort of the problem we're trying to solve. then kind of skip a lot of the work that was done by the Behavioral Health Task Force. A lot of detail in there. You can read it at your leisure before we get to kind of some of the recommendations that we would have going forward, and then talk about that proposed legislation that you as a committee may choose to have drafted or not. So with that in mind, I'm just going to kick it off with kind of looking at the overall funding. This is kind of an overall picture of the funding that flows for behavioral health through the Department of Health specifically. And you can see this kind of red left to right, kind of imagine like a flow diagram. And you can see the magnitude of the flow. Each dollar amount is kind of the width of each of the flows. So for example, at the very far left, we have two main payers, the state of Wyoming, coming from mostly general fund, but also some tobacco settlement funds there, and the federal government. And that's both block grants from SAMHSA, the federal agency that deals with substance abuse and mental health, as well as Medicaid, the federal match there. And that flows to the various agencies within the Department of Health, the Wyoming Medicaid, Behavioral Health Division. And then you can see how it breaks out among providers. So the community mental health centers at the top, CMHCs, receive about $52 million annually from both Medicaid and the block grants that are provided from the Behavioral Health Division.
Mr. Chairman, before I go on, Mr. Fuchs, can you tell me what's the dark brown? The blue is general fund, the gray is federal. What's the dark brown on this lovely looking snake?
Mr. Chairman, Representative Connolly, are you talking about the arrows? The dark there? I'm confused about where the brown is. I just see blue and gray, so I don't. The arrows are just the total. Sorry, the total state general fund plus federal funds.
Got it. Thank you.
Yeah. So really, the focus of this talk is the $47 million a year that goes from the Behavioral Health Division to the community mental health centers. You can see the number here is 52, but that includes Medicaid. So we're taking out the Medicaid funding just for the purposes of kind of what this behavioral health reform is about. Just to kind of give you an idea of how the reform and how this behavioral health reform fits into the larger context of behavioral health funding throughout the state. So those dollars are really broken into kind of two separate kind of pots of money. One is largely residential services, $20 million worth of residential services, and $27 million worth of outpatient services. And you can see on table 3 on page 10, this is sort of the history of that funding. So 47 million is a little bit of a low compared to the history, and that's due to the budget cuts that we incurred last year. So, historically, this funding is, since 2007 has been approximately 50 million a year of total funding. And you can see it's broken there by state general fund, federal fund, and tobacco settlement funds. And the way the funding works is basically we contract with these community mental health centers to provide a certain number of service hours on the outpatient side. So they have to, they get X dollars, and in exchange they provide Y hours of total service hours. And it doesn't matter necessarily who they provide that to or what kind of services get provided. It's just the unit is service hours, right? And that's kind of how the contracts are structured. There are some nuances. You can kind of see on page 11, we talk about how they receive a third of the funding up front in sort of 1/12 payments. And then for the remaining 70%, they kind of have to draw down the dollars based on two separate kind of general rates. So these hours are valued at either $87 an hour for general access clients or $120 an hour for priority populations, which are a little different from the priority populations specified in the legislation. They're more driven by federal definitions from SAMHSA. But there is sort of a differential on that rate. But at the end of the day, they are paid, and basically these contracts are dollars in exchange for service hours, undifferentiated hours. And then for the residential services, they're sort of paid for by basically maintaining a certain number of beds, and they have to also maintain a certain occupancy percentage in those beds. The services are provided to any Wyoming resident, so there's no eligibility criteria, and regardless of the severity of their illness or ability to pay. So it really is this sort of general access model. And kind of why we have this system is, we tried to articulate in the history section why this system came to be, but it really came down to, in the 50s and 60s when deinstitutionalization was happening nationally. Really, there were almost no mental health providers in the state of Wyoming. It really was at a hospital level of care type situation. And so with deinstitutionalization, the goal was to try to build up community mental health centers around the state to be able to provide those treatment services to everybody in the state. And that's the system we have today is kind of a legacy of that historical evolution. So I think the key point from this current status is thinking of the system today as this general access model. It really is there. The state subsidizes these services to provide access to everybody throughout the state. on a hopefully relatively equitable basis. So what's the problem we're trying to solve?
Go ahead.
Thank you. Mr. Fuchs, so I was trying to understand how many people are actually served when I was looking at table 3. And now I understand that your denominator isn't people, it's units that are service hours, it looks like, plus perhaps residential beds. But can you give us any sense of the number of people who are actually served over the years?
Mr. Chairman, Representative Connolly, we actually have some figures in our safety net. When we talk about safety net programs tomorrow, we have some figures there, but it's around 22,000 people any given year are served through this system. Unique individuals.
Chairman, just as a follow-up, has that changed over the years? Or is it a proportion to the population?
Mr. Chairman, Representative Connolly, I could probably pull up our slides for tomorrow, but we will certainly be able to answer that tomorrow in a table. We have a whole table from 2015 to now on how that number has evolved. But it's
Question there.
it's remained around between 20 and 25,000 is my understanding. So back to that kind of that's the current state of the current system we have. What's the problem we're trying to solve? And as the Department of Health, as we see it, we have a kind of twofold problem. The first is that we as the state spend a significant amount of resources outside of this community mental health center system, state general funds, serving a relatively small handful of people. And by that, I mean in the hundreds or thousands in institutional settings. So we're talking about Department of Corrections, the state hospital. And a lot of people are going through these systems over and over and over again. It's sort of a revolving door that happens. Like a third of the clients in the state hospital have been through the state hospital at least once any given year. And potentially those folks could be cared for more effectively and economically in the community. So that's kind of the first kind of aspect that we're looking at. The second problem is that the system that we have today was really built when general access was really important. But our point here on the second bullet on page 12 is that times have changed. The system is not perfect. There's obviously still gaps in the system and affordability in terms of access to providers, but there's a dramatically different landscape of access to mental health services for the general public today than there was in the 50s and 60s. And we have, both in terms of access to providers, the number of actual physical providers living in state or licensed to provide services in state, and the ability to pay for those services through insurance regulation. So there's federal insurance regulation has basically mandated that insurance plans cover mental health services to the same degree they cover physical health services. And they also have established significant subsidies for both premiums and cost sharing for low-income individuals. So there's broader access for the general public and specifically for lower income individuals, at least if you're above the 100% cutoff for the Obamacare exchange, to mental health services, right? So those are really the kind of the two aspects of the problem that we're looking at today. And you can see some substantiation of that. For example, figure 3, we're just looking back to 2000, just 20 years. The number of providers in many cases, has doubled in many counties. And we're not saying there aren't gaps. We're not saying there aren't still, issues accessing care. That's not what we're saying at all. What we're saying is that, if you extrapolate back to 1950, the situation has changed. That's all we're trying to say. And that the system built for that 1950s world should likely change as well. So again, that's by county. You can see by provider licensure. And then we also have a per capita amount on, basically standardizing for population on the figure 4 on the next page. Kind of the number of licensed providers per 1,000. And again, not a perfect indicator, right? We're using licensing board data. Not all of these providers actually practice. This is sort of a proxy, right? A proxy measure for how access has changed over time and across space. It's not necessarily the absolute number that are available to any given person today.
Clarify? Okay, thank you. And so that would include people who are retired, who just keep their licenses. It would include school counselors, for example, who have no ability to take clients as examples. So it's really a very rough proxy.
Mr. Chairman, Representative Connolly, that's absolutely true. I would push back a little bit and say that unless the proportion of those people has changed significantly over time, the trend is really still meaningful, right? So unless there's more people now that are retired or more school counselors than there were 20 years ago, unless that number has changed, this trend is still, I think, a valid proxy for kind of overall access.
Yeah, and Mr. Chairman, the one I did think about is school counselors, which in fact have changed significantly over the past couple of decades.
So, Mr. Chairman, continuing on, we talked a little bit about affordability of services. So again, page 15, we talk about kind of the requirements for mental health parity and the subsidies. And again, there's still gaps. Just because mental health parity is required doesn't mean that insurers actually cover all services or all amounts of services required by people. We're not saying that, but we are saying that the nature of insurance has changed significantly since these regulations were established, and particularly since the 50s and 60s. And then you can see the table there kind of shows the premium and cost sharing. So not just the premium, but also the copays and deductibles. There are subsidies for those too. And you can see how those are, available, generally speaking, for people between 100 and 200% of the federal poverty level. For general, this is all medical services, but it would apply to mental health as well.
I've been really trying to understand it, and I had a hard time understanding this table, trying to understand what's the difference between a premium subsidy and a cost sharing subsidy, and who pays it and who gets it.
Mr. Chairman, Representative Collins, that's a really, there's a lot of nuance to that. The premiums are basically the monthly premium you pay for insurance, right? So you can go to an exchange and get a premium, and you can see these benchmark premiums, which is a silver level. And I'm forgive if I get into the weeds on the Obamacare exchanges, but basically the premium is capped at a certain amount of income. So a lot of people can find premiums for less than $20 a month in many cases, if you're within certain income bands. And then on the cost sharing side, that's going to be when you actually use medical services, your deductible, the co-pays, the co-insurance. There are subsidies for that too. I mean, there were subsidies explicitly for that. In 2016, the Trump administration made the decision to stop those subsidies. And so what insurers have done is they still have to offer those plans that have the minimal cost sharing, but what they've done is baked all that extra cost into their premiums. And that's had a whole host of random effects that we could really get into. It's really convoluted and really complicated. And I don't want to spend all the time talking about the ACA and insurance, but basically, at the end of the day, these plans still offer very generous and highly subsidized policies for people that are between 100 and 200% of poverty. If you're below 100%, you're not eligible for these plans. And if you are above 200, those start tapering out. You can kind of see how the table shows the plan covers less and less of the medical costs, and the premium subsidy cap gets raised. So at the end of the day, those are kind of the issues we're trying to solve. We sort of delve into more detail on that. So for example, for the first problem, when we're talking about people falling through the cracks in these institutional settings, figure 5 shows Title 25 costs over time. So historically, we've spent about $10 million a biennium on Title 25, which is the involuntary hospitalizations that are outside the state hospital. So WBI, which you'll be touring later, is the prime provider of those services. We had a big high in 2016, 15-16 biennium of almost $18 million, and that caused a lot of consternation, which has been, the trend has gone back to normal levels, but we are expected to spend around $11 million this year on Title 25 at the end of the biennium. And then you can see on Title 5, Table 5 and Table 6 kind of show that approximately 40% of people, both in the Title 25 system and in the correction system, are not being seen at all in the community mental health system, which is a pretty big fraction. So when we talk about falling through the cracks, we're talking about 40% of people not being seen at all. And it's not necessarily the community mental health center's fault. It's people don't walk in the door, they're not going to see them. So if 40% of people never show up, then that's they're not going to be seen, right? We don't have the incentives. We're not paying the mental health centers to go out in the community and actually find people and bring them in, right? It's really, again, on that general access model. So at the end of the day, when only 50 to 60% of people are being treated in these community mental health centers, that's a significant number of people that aren't, right? And the results we can kind of see on, we did some work for the Justice Reinvestment, which you may have been involved with or heard of, on figure 6. You can see that just purely correlations. We can't say that the behavioral health services caused lower recidivism, but it's certainly associated with the receipt for high risk, specifically for high risk people coming out of Department of Corrections, which is the bottom right panel here. Those that received mental health and substance abuse services had significantly lower recidivism than people that did not. So there does appear to be a correlation of receiving services in the community and not going to the institution as often. And I think that's promising and it's logical. And ideally, the problem we're trying to solve here is redirecting the sort of the mission of these centers to focus on these sort of priority populations so that recidivism ultimately, we can improve recidivism, we can lessen the burden on the state hospital, and we can sort of improve treatment in the community and people staying in the community as opposed to going to institutional care. So that's sort of a really high level, really high speed summary of the current situation as we see it and sort of the problems that we're trying to solve. And I wanted to stop there before I take any questions before we move on to the kind of recommendations that we had going forward for this process.
Any questions, committee? Go ahead.
Mr. Chair, going back to page 15, at the bottom, after table 4, there's a sentence that says, and that there are still provider shortages across the state, that regardless of what looks like positive trends on figure 3 and flat lines on figure 4, there's that sentence there. Can you talk a little bit about that sentence?
Yes, Chairman Baldwin, Representative Connolly, the whole state of Wyoming, I think, is a mental health shortage area per, I think, the Health Resources and Services Administration. So there is, every county in the state is sort of underserved by professionals. It's not just, so that is a meaningful sentence. There are shortages, well documented compared to other states. I think it's an important point to mention. Yeah.
Further questions, committee? Go ahead and proceed, Franz.
So, Mr. Chairman, members of the committee, we have the bulk of the report is really the recommendations of it's been developed or the work that was done by this committee specific to eligibility, outcomes, and transitions. And you certainly can read the report on that, but really I want to talk to you today about sort of the next steps and recommendations, because this committee will be the one that would have to either basically pick up a bill that we're proposing at the end of this presentation to continue the work going forward. So I kind of want to talk about the recommendations going forward.
Go ahead.
Page 39.
Before we go on to the kind of the redesign process and kind of maybe modifications, I was curious about need and looking for kind of graphs about both population and the need, and curious about what's the evidence that you were looking at regarding kind of the need in our state and by county, et cetera.
Mr. Chairman, Representative Connolly, it's a really good question. I'm not sure. I think it would depend on how you define need. There's statistics we can access relating to for example, the behavioral risk factor surveillance survey. They go out and sample a couple hundred folks every year and say how would you rate your mental health 1 through 5. Are you experiencing depression? There's social surveys out there that we could potentially look at, but they're surveys. They have a relatively low sample size. The fidelity at the county level would not be, to actually look at differences across counties. So it really depends on how you define need. Is it just sort of your self-assessed needing for mental health services? Is it recidivism? Is it looking at Title 25 exposures? Like, how would you define need, first of all? Because that's really, I think, the critical prerequisite to start with.
Yeah, thank you, Mr. Chairman. And exactly. And so honestly, I was looking for that and other things. For example, waiting lists at community mental health centers, practitioners that aren't taking any new clients, for example, who are included in the counts, all of that. But it would seem to me that anything we do has to be predicated on understanding, as you talked about, like what's the problem? And to me, the problem is not, I don't want to think about it only in terms of money. I want to think about it in terms of providing services for our people, and that would be based on need. So I am curious how the committee has talked about the need and how we'll provide the services based on that need.
And Mr. Chairman, Representative Connolly, if I may, to Franz's point about, I think there's different and competing interests sometimes of what need is, and it comes back to what's the role of the state, not with the entire healthcare, or in this case, behavioral healthcare system, but specifically with what you all have entrusted us through statute and through budget to provide. The needs that are articulated for this process are in the report and can be debated. Are they overly narrow? Potentially from different perspectives. My point would be that from the state side, we have needs that we're seeing really create some externalities and some failures in the system, specifically around high needs and higher acuity populations, whether that's at the state hospital through Title 25 and Title 7. As Franz mentioned, the correctional system, where we have good data that supports two things. Number one, that a lot of folks with those high needs in the correction system are coming out of the correction system, are not getting the care that I think they need for a variety of reasons, and also recidivizing, if I can invent a word, back into certain state systems or correctional systems. Third, which we haven't talked about here today, but it's certainly in the report and a big part of the discussion, is again, a relatively small proportion of high needs children and families where we mostly on the Department of Family Services side, but also in the Medicaid system, we end up really struggling to find out-of-state placements for more challenging behaviors, both with the child and with certain family elements that contribute to those behaviors or conditions. And the Department of Family Services and our department really struggle with, again, we're talking handfuls, relatively speaking, of people that I don't believe we have set incentives appropriately with some of our community services to prioritize them. While still, I think the balance we're trying to strike is, to your point, what do all of our communities need, and folks who don't need a lot of care or are at lower acuity levels. And that's where the argument comes in on the role of the state, that while not perfect, there are other systems, non-general fund systems that can provide some of that financial support to people to have coverage, but also not, we don't have to have the state dictate a community mental health center's business model, where if that service can be provided and be provided at scale to folks on the lower end of the continuum of need from the state's perspective, then by all means provide it, but it won't be prioritized with state dollars. And that's really the fundamental and philosophical shift with some of this reform effort, is to shift some of that role of the state to focus first and foremost on that sort of tail of the population that we really see slipping through the cracks of society in many cases and ending up cycling through institutional type settings. So I will say, Representative Connolly, through you, Mr. Chairman, it's a tough debate. It's a philosophical and societal debate of where should those dollars be prioritized, recognizing that we likely at the state level cannot be all things for all people. And that's certainly the case at the Department of Health.
Senator Hutchins, you had something?
Is she finished? Okay, thank you, Mr. Chairman. Either one of you can answer this question, and I have two. One kind of came up as you spoke. What are the age ranges you're seeing an increase in mental health issues?
Mr. Chairman, Senator Hutchings, happy to provide the breakdown by age of the clients that we see served through community mental health centers. I don't have that data in front of me, but happy to provide that
Okay.
to you after the committee.
Follow up, Mr. Chair. Thank you. You said something that kind of piqued my interest. We talk about incarcerated people getting out of jail, and then they're going to need mental health. If I'm incarcerated for 5, 10, 20 years, why aren't you working on me while I'm inside?
Mr. Chairman, Senator Hutchings, that's a great question, and would certainly on any details within the walls of the correctional system refer to Director Shannon. But some of that work is kind of running in parallel with this reform effort. And it was a couple of years ago that you all passed House Bill 31, which really directed additional collaboration between the Department of Health and Department of Corrections for that type of care that happens not only after institutional care in the correction system, but in the community through supervision, probation, and parole. That work has been going on in conjunction with this. So I think improvements are being made there, Senator Hutchings, and happy to defer to Director Shannon for a more detailed report on that.
Thank you.
Go ahead and proceed.
Okay, so ultimately, we're just glossing through all these, the work products of this report. Just kind of talking about the way forward. there were a lot of things that were not discussed, and the work really is incomplete. So we were basically asking for more time to kind of consider these kind of topics. For example, like the essential subsidy payments, how those would be allocated, how pay for performance, basically linking outcomes and payment would function, integrating residential services and how that would work, and then repurposing the existing funding. So we have some recommendations here of kind of how, what we see is sort of the way forward for tackling those kind of questions. And kind of the first, the thing we took was, okay, well, let's do a little survey, of the legislators on the steering committee, the executive branch members, and the providers. Let's say you have 3 different buckets. You have fixed payments, so basically payments that are made just to keep the lights on, that are made regardless of service provided or people seen. You have a bucket for services that are basically very similar to the medical model that we have now, where you go to the doctor gets paid, right, for that service. And then you have a bucket for outcomes. So if you had to divide the total payments into those 3 buckets, how would you allocate the overall funding for this system? And the results of the survey are on, there's a kind of complex diagram on figure 9, but at the end of the day, the bottom line result was that the survey respondents recommended a 40% of the money be allocated to fixed payments, 40% of the money be allocated to service-based payments, and 20% of the money be allocated to outcomes-based payments. So that's just some information for the committee. That's, I think, a percentage that we have to kind of refine, and we'd certainly love anyone's, folks' thoughts on that. But that would be kind of our starting point for figuring out how the payment would work, is really looking at those first 3 buckets up front. And so our recommendation is kind of taking that starting point and saying, we should do this according to this average, 40%, 40%, 20%. And with a $45 million approximate budget, you can kind of see how that breaks down. This is bottom of page 41, just for people tracking along.
Mr. Chairman?
Yes. Representative Conley.
Thank you, Mr. Chair. I love this graph. I love some of your graphs, are pretty cool in here, and this is one of the cool ones. However, that being said, when I looked at it, I did take an intake of breath, because it seems to me that the legislators are at a far end from the providers in terms of thinking about the money. And honestly, this is going to go to, in some ways, how the money is allocated. Is that a fair assessment of looking at this graph?
Mr. Chairman, Representative Connolly, I wouldn't say far. I think the far end would be the very tippy top. They were certainly, if you think of the center as being 40, 40, 20, which is kind of where I'm putting the cursor right now on the thing. Then the legislators were kind of a little more on the outcome side. Executive branch was more on service side, and the providers were more on the fixed side around that point.
Thank you, Mr. Chairman. So Representative Connolly, if you're looking at it from there, it's hard to see, but if you look at it on paper, that far right lower group is actually the non-WAMSAC providers. They were the ones that were, the other 3 are actually they even overlap the other 3. It was the non-WAMSAC providers that are off there in the corner. So I don't think the legislators were particularly, there's a fair amount of overlap, or at least they touch.
And Madam Co-Chair, that's 2. It's an N of 2 for that group. For the group in blue on the far bottom, it's a sample size of 2 people. So the model is very uncertain about their preferences, but they were very far on the service side. And we sort of considered, given that the stakeholders are really the WAMSAC providers, we wanted to look at the WAMSAC providers, the legislators, and the executive branch members as kind of the 3 main groups of interest here.
So, Mr. Chairman, just to be clear, so when we talk about some of the differences between fixed outcome and service, fixed is, is it true that fixed is basically what does it take to keep the doors open of a particular center, for example? And that, in all honesty, that is something that in a small state or smaller communities, let's face it, that even if they have only 2 clients coming in that day, they still need to pay their power bill. Would that be a fair way to think about this in some way? And so that fixed cost could vary significantly among and between areas.
And that actually, Mr. Chairman, Representative Connolly, ties into our second point when we're talking about the essential subsidy payments. We would consider that part of the fixed kind of bucket of payments there. And we would actually try to figure out a formula for those essentially subsidy payments that reflect kind of maybe the differences potentially in county costs. Essential subsidy payment in Jackson would be very different from an essential subsidy payment in like Crook County or something, just based on the cost of real estate, the cost of living and everything else. So I think we do have to sort of account for those regional differences or county level differences when we're talking about those fixed costs. Our next recommendation is looking at service-based payments. And really our recommendation here is leveraging existing infrastructure. So the state of Wyoming has made significant investments along with the federal government in our Medicaid system. We have a massive new data warehouse. We have a new claims processing system, a whole new infrastructure that works very well in processing Medicaid claims. And that system, since we've already paid for it, we're already using it for Medicaid, that system can be leveraged to do the payments for this system as well, if we were to so choose, as opposed to building a whole new separate data system just to do mental health. We could just kind of fold that into this Medicaid. Now, it wouldn't be paid for by Medicaid necessarily, but it would allow coordination of those benefits. So if, for example, it's a service-based payment, but it's going to a Medicaid client, we could figure out, the provider could send one bill to us and we could figure out on the back end whether Medicaid should pay for it or whether the general fund should pay for it using this system. So it kind of allows those efficiencies that would happen automatically just from the back end of that infrastructure. And then really the goal here is growing the pie. So trying to maximize other pay sources. So not just use state general funds for everything. Try to get insurance, Medicaid, Medicare, other pay sources to pay for it before we use that general fund dollar, because those general fund dollars are scarce. And so that might help grow the pie a little bit by adding more additional revenue into this system. For the outcomes-based payments, our recommendations that they be implemented gradually and rigorously evaluated. So the recommendation was at that 20% allocation. We're saying instead of that, let's try 10%, let's reduce that, and let's do it on sort of a pilot basis. So let's do sort of a rigorous randomized controlled trial with certain people being sort of tagged for their outcomes being paid for, and actually doing a randomized controlled trial to see if paying for outcomes actually causally improves those outcomes. And so that would give us evidence, either for or against. If it doesn't work, then we shouldn't be doing it. It's kind of the first rule of beating your head against the wall. Stop. If it is working, that would be good evidence to proceed and expand, right? So that's kind of a recommendation for the outcomes-based bucket. And that really gets us to our proposed legislation, unless there's any questions on some of those recommendations going forward.
Yeah. Okay, so thank you. I'm curious about the whole outcome section when I was thinking about it and thinking about money being tied to it, because certainly you can't make an argument that outcomes should be based on less mental illness, for example, right? I mean, that would be the equivalent of saying that a provider failed because I don't have 20/20 vision, even though I've been wearing glasses for 50 years now, right? That doesn't seem at all reasonable. But then in here talked about the importance of, for example, the wraparound services that were talked about this morning, the need for more community-based, I don't know if I want to call them halfway houses or kind of secondary places for people to move to, transitional housing, things like that. But that in the report, it seemed like the committees were not able to address those issues well enough at all, not at all. And so we're just out there without really getting a sense of this portion right here. So that concerns me when we don't really have any either great data on outcomes measures from anywhere else. We don't have much in terms of what we can do as a state in terms of those other elements like getting housing in Jackson or even Laramie, to tell you the truth, right? So how is it that we're still going to tie money when we don't have answers to those kinds of questions?
So, Mr. Chairman, Representative Connolly, the work that was done this summer was really on the outcome section, kind of coming up with a list of outcomes that the state is interested in. But as far as when you actually start talking about payment and about tying the dollars to that, I don't think that conversation hasn't been had, right? So we started with what are the outcomes that are really important to at least track. And those are really, at the end of the day, the most important ones are these community, commonsensical community integration type outcomes. Are they involved in their community? Are they housed? Are they working? Or at least volunteering? Are they not in jail? Are they not in the state hospital? These are really relatively easy to conceive kind of outcomes. We're not trying to track some kind of mental health status, right? Trying to measure that, which would be really, really difficult, to your point. So the outcomes, I think, are really not basic, but I think fundamental is the word I'm looking for. They're not sort of based on some kind of measurement construct that'd be very hard to measure. It really is, are you in the state hospital? Are you not? Are you in jail? Are you not? Are you housed? Are you not? You know, are you going to school if you're a kid? Those are kind of outcomes that are really important, I think, to everybody, you know, and I think we all agreed, the stakeholders, the legislators and the executive branch members spend a lot of time going through this list, and we all agreed these are the ones that are really important to track. Now, the conversation of how you pay for that, is it fair to penalize a provider for someone not being housed? That's a real good question. And that's a question we have to have going forward on, like, how much risk do you put on each of these outcomes? How do you weigh them? How do you tie the dollars to it? So you're incentivizing the providers to achieve those outcomes, but not unfairly penalizing for something that's out of their control. I think there's a real balance that needs to be struck when you're talking about that, how the money gets tied to these outcomes. And we unfortunately do not have the time for that conversation. And I think that's going to be a really big focus on the next iteration of this redesign.
And Mr. Chairman, if I may, Representative Connolly, this has been a discussion in what should a mental health reform at the community level in Wyoming look like for years, for as long as I've been with the state. And it always comes down to a question that gets asked, whether it's at the committee level or in our discussions with providers or with consumers of the services, that we know that especially on the higher end of the continuum of need or acuity, that some of these socially determined outcomes correlate with better outcomes for, you know, less reliance on higher levels of care, less symptomatic issues or recidivism into other state systems, for example, that housing, education, employment, access to insurance or pharmacy. These are all things that I think are important for a behavioral health population. And to Franz's point, the question comes to all of us, who's responsible for trying to do something about those outcomes, knowing that there's a lot of exogenous variables that one entity like a provider group or even the state can't control, like the housing market, for example, or housing stock. So we're trying to strike that balance between getting those incentives right, but also not giving up on that, because everybody likes to talk about social determinants of health. The time when a system or a state or an insurance company or what have you starts to play with the money related to those social determinants of health, then everyone starts to disagree and break down. I think that's what it's going to take to change this, is in collaboration with our providers. And to my point earlier, this has been a very good process so far. We don't agree on everything, but we agree that there's a need to move forward with trying something different, potentially. And over the course of the next interim, maybe even 2 interim periods, I think getting that balance right of what is that upside risk where we are rewarding providers, whether it was through minimal or maximal effort for achieving those outcomes that we know correlate with better lives for some of these people. And that's really the challenge that we don't have resolved yet. But I think what you see here in the proposed legislation is to allow us to continue that process, to continue that evolution of what this system should ultimately look like when we turn it on, whether that's in 2023 or 2024. That's really the idea. And I think Wyoming's positioned right now to be really innovative in this space with what a state-funded community mental health system looks like for folks that often systems, including state systems, give up on, to be quite blunt.
Just to follow up, would it be accurate then to say that the need to really define this better and to actually start establishing those wraparound services is part of the reason that you're asking for at least another year, if not more than that? Okay. Because I couldn't agree more that those things are really important.
So to flush that out a little bit and Representative Collin and others, so I've been on this working group, but if I can take a parallel from physical health, Medicare has gone, and I might be not speaking perfectly accurately because I'm not involved in that, but Medicare has gone to where, let's suppose a cardiologist and a surgeon do some sort of cardiac treatment on a patient, and then the patient goes home and doesn't do his PT, lies on the sofa and eats potato chips, and ends up back in the hospital again within 30 days. They won't pay for his second visit because they're like, your guy was re-hospitalized within 30 days. Too bad for you. Is that really the physician's fault? No. I mean, it was paid. So, and I'm not saying that the mental health thing is having to do with choices like that, but I'm saying that there are other insurance providers have gone toward, and so even though from my point of view, it's not really the provider's fault that the person is back in within 30 days, what it did do, that whether I like it or not, what that payment approach did was incentivize the provider's office. Now they call you after you've been discharged. They have the case management type stuff. And so what I see happening with something like this is as Director Johansson has said, is we still need more work. And I agree with the year-long stretch out, but what that does do is really incentivize the case management, the wraparound type services, the follow-up, which I think are really key, rather than just sort of a process-oriented thing of, I saw the patient on Friday at 3 o'clock, I saw the patient the next Friday at 3 o'clock. Well, that's great. What have you made their life better, or did you just see them every Friday at 3 o'clock? And I'm not saying that people did that exactly, but I think that as long as you structure the incentives so that you're not penalizing the providers for something that truly are beyond their control, but you do incentivize them to spend that contact, that kind of chasing things down, that communication with other providers in the community, I think that will be better, lead to better outcomes for the clients.
Senator Hutchins.
As I'm listening and I'm hearing, let's talk about outcomes. And in my mind, I go to, what are the incomes? And by that, I mean, what is causing all this mental health? Do you have a list of what's gone on in the past 70 years, what's changed in our culture, what's changed in our society that's causing this problem? So if we can get to like the root, the foundation, why are people going this route? Well, we have to spend as much money and time dealing with outcomes if we know what the incomes are and we can stop it.
Mr. Chairman, Senator Hutchings, that is an amazingly complicated question with a more complicated answer that I probably don't have. In terms of the prevalence of mental illness, especially your, again, higher acuity mental illnesses, schizophrenia, things of that nature, there's certainly medical data and studies out there of how that has changed over time, or if it has changed over time. The way I would answer your question now is going back to Franz's point, and it's really fleshed out in the history section, that none of this prevalence is new. Do we know the underlying biological or social causes of mental illness? I certainly don't. There's probably expert testimony that could flesh that out better. But I think how society in the past has handled that prevalence of mental illness was often through more institutional type settings. And then in the mid part of the 20th century, as Franz mentioned, we started to change that through more provision of community-based services. So has that prevalence changed over time? Has it gotten worse in recent years? It's really hard to say. We know it's there, and we see it again. I won't speak for other systems, but systems that I specifically manage or control is at our higher levels of care in the state hospital, in our congregate care setting, group homes, crisis facilities. Like I mentioned before, correctional settings. We're still seeing that, and this would be trying to address that differently through provision of community services and tying the funding directly to that.
So, Mr. Chairman, just to wrap up, we have this proposed legislation that we'd submit for your consideration is for LSO. Really what it's doing is a couple things. There's section 1, which modifies. So with the eligibility committee kind of went through and found some just little tweaks to the previous House Bill 38. So there's a couple tweaks in there in section 1. For example, changing the title of adults with acute mental illness to adults subject to Title 25, adding some clarification under families of high risk under section Romanet 16, I'm really having trouble, 17 C. So there's, again, section 1 is really these tweaks to kind of the eligibility criteria that were uncovered by this work group. Section 2 kicks back the date. So we basically amend the session laws to basically kick it back a year. So from 2022 to 2023. Section 3 would basically have the concurrence with the recommendations in this report by reference. And that we would certainly recommend, if you do not concur with these recommendations, that there be some suggestions for future, where we should be going, because this report is kind of how we see us taking this reform. If the legislature disagrees, we'd certainly love that guidance. So we'd recommend, putting that in section 3 if you do not concur with those recommendations.
Mr. Chairman, I might just add to Franz's comments that this recommendation on the statute modifications, we're saying we, it means the royal we, and Chairman Baldwin and Wilson can certainly speak to this too, that this really came from the steering committee, which included both the two chairmen here, as well as Representative Larson, Director Shannon at DOC, Director Schmidt at Department of Family Services, and then health participation as well. And Franz, I might have missed a few members of the steering committee. It's fleshed out in your report, but just wanted to make it clear this isn't Stefan and Franz's recommendation for how to solve all the ills of society. This came through that process.
Thank you for the promotion there, Chairman. On section 1, where you're talking about the kids, children being discharged from acute psychiatric facilities, was the school district brought in on this steering committee? Because one of the problems I've seen is these kids go through the therapy, they get out, they graduate from their thing, come back to the school districts, and they get put back in the same program they left to work their way out of there, back into the regular classroom. That within 6 weeks to 6 months, their behaviors turn back like they were before they left, and they end up back in an acute care or another facility. So has that been addressed?
Mr. Chairman, Representative Stivar, we did not specifically talk with WDE or the school districts in this process, and we certainly could going forward to try to refine that. But I do think, to your point, when someone becomes eligible under this priority population, it wouldn't just be for a brief period of time. So in theory, to the scenario you're talking about, someone coming out of the school district someone coming from an acute psychiatric facility, if they're now a priority population in this system, they should be receiving services continually. And hopefully that avoids the situation where they dump back into the, maybe the prior setting and have to come back out to the acute setting. I don't know if that answered your question or not, but we can certainly, if collaboration with the school districts and Department of Education is, going forward, we can certainly do that.
Mr. Chairman, gentlemen, this is big. It really is big. What I'm wondering is, with the new House bill that was put into effect, and with the budget session coming up, so you're not quite sure, would it be good to even extend this to 2024?
Mr. Chairman, Representative Ottman, it's a good question. My recommendation from the health department's perspective would be to extend it for 1 year, because during the interim period, that can be reconsidered again, depending on where we are. The reason for that is for our accountability, as well as the reform efforts accountability, to make sure that we're not resting on our laurels, so to speak, because we have 2 more years of implementation. We worked very quickly over this summer with the provider group. And again, we acknowledge that we did not solve all of the problems or address all of the issues. So we'll be upfront and transparent about that.
I would add to that further that the coming year after this interim is an election year. So the makeup of the legislature and perhaps this committee may change subtly. Who knows?
Say it ain't so, Mr. Chairman.
But you saw how much the legislature and this committee changed last time. It could substantially change again. So that may have an influence. So I would concur with the Department of Health.
And then just the final point here is section 4, basically looking at for ARPA funds to develop provider capabilities, claims processing, eligibility determination, outcomes infrastructure. So we have an opportunity now to use federal dollars that are already given to the state to make the changes necessary to implement this system. So that's all section 4 says, is to use those dollars and come up with a request and estimate for how much that would cost. So, Mr. Chairman, with that, that's the end of our presentation. I hope that was quick, but somewhat comprehensive.
That was exceptional. Sure. Questions? Senator Bouchard.
Thank you, Mr. Chairman. So when I see legislation that's made to reform, I always come back and I look at things that I've seen in the system that kind of never comes out till later. And so, because it bothers me, there were children that were adopted out. And then then the parents were stipend. And then they were troubled children. And then they go back into the system while they're being stipend. Right, and I'm sure you're aware of this situation. And you, as a legislator, you don't find out unless somebody tells you. And so now we're doing reform legislation, and I just want to know if there's a way that somehow this committee can be aware of the mistakes. I mean, we need a page in here that says it should be in here and it should say screw ups. And because that's the problem, is we don't get to see that. Does that make sense? I mean, so now we're going to do reform, and we don't know if some of those things that got messed up. And we've got maybe a chance to fix some of them when we're pushing legislation forward to reform. So, I mean, I'd almost want to see, and I'm not for reporting, because then we get too much just reports that we can't keep track of. But I think there needs to be something where, you know, this is where we messed up. And we need to make sure this doesn't happen again. Not so much for the people that are here today, but what about when the committee changes and then tomorrow? And then somebody knows the institutional knowledge 4 years ago. And now today we never knew it happened. So if that makes sense, there needs to be some kind of historical, so we don't make the same mistakes again. So we look at things and systematically improve. So I don't have a solution, but I certainly would like you to work on that part of this. We have a historical basis to look at things and make sure that we're not going to make the same mistakes again. And that not just when, so that way the we that you mentioned all has that institutional knowledge to make sure stuff like that doesn't happen again.
Mr. Chairman, Senator Bouchard, I think I understand what you're getting at. I would say that this reform effort is less a result of responding to specific mistakes or instances where kids slip through the cracks and we had the wrong kind of outcome. This is more of a macro approach of how do we take a relatively large line item in a budget of a state agency. And this, as you saw in the funding graph, this is our second or third largest line item that we can do something different with because we see certain areas where it isn't working. So I would hate to say, there's an ability to report on all of the failures of a system. They're certainly there, as are successes of folks who gained access and could go to their center in town and get some help. But this is much more of a macro view, but point well taken. We'll certainly take that under consideration if there's a way to keep where it's not just me, that's the institutional knowledge of where these reform efforts have gone in the past. We'll certainly work on that.
Go ahead and follow up.
Thank you, Mr. Chair. So just to follow up, so understand, and I want to be clear that this is stuff that can't be just found by members of this committee. We would have had to know where to look for it, where to ask you for the reports, because the problem, and I'm just going to be blunt about it, that government makes mistakes and it doesn't necessarily say, hey, we want to tell you about it. And that's where I'm going with it. We need to have some protections there somehow going forward when we're changing systems, so that way this whole committee and everybody involved, because I mean, we redact the personal information, but it needs to be so people are aware this is what happens when we make these kind of mistakes, because it's good for the people in this committee to know these things and how things like that happen. By maybe we could have changed one code in law, one section of law, and we could have stopped that from happening. Because, and I haven't pulled all that information, but it's pretty drastic. It kind of changes our outcomes when we're spending that much money and not getting the outcome that we want. So, and I'll leave it at that.
Representative Conley, go ahead.
Yeah, thank you, Mr. Chairman. And before you get off of the seats here, so it's my understanding, at least from reading the report, that you have proposed legislation here. So I'd like to ask you about, so I have some questions, but also about some suggested modifications that I would make and what you think about those, if that's okay. And so on section 4, I don't want to work backwards. All right, section 4 says that it's the intent of the legislature to have you ask for ARPA funds for many of the items that are in the report. What I didn't see here was transition services. So I'd like to add that in there. It seems to me that that's an important element that is part of that outcome measure. Now, I'd like to add that in. Do you see any problem with that?
Mr. Chairman, Representative Connolly, I don't, only in just one caveat that with American Rescue Plan Act funds, and we'll talk about that when that section comes up, there's competition over those funds, and I think some priorities around them where this is kind of one-time investment opportunities. The reason the steering committee kind of agreed to that language, when there could certainly be additions, it will just be to the ability we could finance them through ARPA, might be up in the air. These would, as you see here, provider capabilities, system changes, eligibility, systems, that would be one-time investment that we would recommend, providing this provider system so that that's not another cost that's absorbed as a result of a reform. Secondly, Representative Connolly, I would say, and we'll update the committee, I believe tomorrow on the ARPA plan. That is one thing that is under consideration for the Health and Human Services side with ARPA funds is an account or something similar that could be set up. And again, it will compete with every other ARPA priority that could provide over the next couple of years within that time frame that those types of transition funding for those types of transitions. What we know, just one example very quickly, Mr. Chairman, is to provide higher levels of care in the communities to some of these patients or residents of our state that we're talking about. Higher levels of care, higher levels of practitioners are needed that are not always available in our community mental health centers in different communities, psychiatrists, psychologists, et cetera. So funding like that, I think I would certainly support an ARPA proposal that could maybe help that transition, help these business models adjust to some of that need that we may see evolve over the next couple of years. So those two things, I think, would be my response.
Mr. Chairman, then just to jump on that, so you're very prescriptive on how those ARPA funds would be used. And that is why, because of competition for those funds? I mean, can you be less prescriptive and then you have more flexibility?
Mr. Chairman, Representative Flintner, good question. Just clarify where I was unclear. When I say competition for the funds, I'm talking about the funds that are currently in the state's possession in the governor's office that can be spent in a variety of ways, but with some sideboards that the federal legislation has. Competition for those funds will come because there's a lot of different investment opportunities for the ARPA funds, and the governor has to consider those, the legislature has to consider those. So it's not necessarily if we got funding that we would have to be overly prescriptive on those. They would just need to fall within the side rails of the federal legislation. But when I say competition for the ARPA funds, that will be the case for all of the different ARPA proposals that you will see should the state invest in unemployment insurance, in Department of Family Services areas, Department of Health areas, energy areas, environmental areas, trail maintenance, that all of those things will, what I meant would be competing priorities.
Mr. Chairman, keep on going. Okay.
Go ahead.
The other thing I was considering is with section 3, where you'd like us to agree with the report. It seems to me a good portion of these was talking about what you weren't able to do in this year. So thinking about adding a line that would say something along the lines of, it's the intent of the legislature that the steering committee continue to address issues identified in this report. Okay. All right, now here's my question. It goes back on the previous page. And it's on 17C, where it's a child who's been referred to a behavioral health center. It looks like the steering committee has now kind of listed a relatively small group of individuals who can make that recommendation. So I'm curious about that list, but also about some others who I've thought of who could I think, make that recommendation as well. Like a guardian ad litem would be one, a therapist would be another one. So again, curious about the existence of a new laundry list and some of the omissions that I see.
Turn your mic on there.
Sorry, Mr. Chairman, Representative Connolly, that addition was part of a discussion on the balance between providing services quickly versus trying to get a sort of a comprehensive assessment of a child's needs. Because right now, if you look at, without that language, it's a child who has been referred to a behavioral health center by anybody. It could be their parents, it could be, it's completely open-ended. And the discussion focused mainly on, well, if we trust that the referral source is really these entities would be really trusted, that any referral that came from them would definitely be a child with high needs, then we wouldn't have to do as much assessment on the other end, and that service could be provided more quickly. So the idea was to kind of build like a list of not gatekeepers, but people that would referral sources that if you get a referral from these sources, with high probability that child requires treatment for mental illness that impacts the child's life, and treatment is necessary to prevent the child's involvement in the judicial system. Because without that, you have to assess, how do you know the treatment is necessary to prevent the child's involvement in the judicial system per statute, right? And that was kind of the tension that we were looking at, was the availability and rapidity of the treatment versus the assessment required by statute, or the criteria there.
It would be to add in at least those two others. But I'm now curious, and I must admit, I argued this one on the floor a lot, and that the portion of the last sentence that says that a child who has been referred has to also have evidence that the treatment is necessary to prevent the child's involvement in the judicial system. And honestly, I'm curious about the discussion in the committee, because prevention is almost impossible to measure. And how would you go ahead and prove that this treatment is necessary to prevent a kid from being arrested or in trouble? Do we really, I don't see us really needing that sentence. It bothers me to no end.
Mr. Chairman, Representative Colley, that's exactly the reason why we have the referral sources, because we were going through all these assessments that could be done on kids, like the CASI. There's always a whole acronym soup of assessments that could be done. None of them are really tailored to this kind of criteria. So the idea was, well, if we can put a list of referral sources, then by rule or by execution, the department could just say, well, anyone referred by these sources would be presumed to have that risk of involvement, without necessarily having to develop an assessment tailored to that criteria.
So, Mr. Chairman, if I then, like, my compromise is to add a GAL and a therapist, we can then get rid of that end of that sentence, and it gives me a whole lot less heartburn, because you just told me that that your assumption is now, with a laundry list of professionals, honestly, you're going to per se meet that requirement. And if you're going to per se meet that requirement, we don't need it, especially as an and in the sentence.
Actually, Chairman Wilson, we're supposed to ask lots of hard questions. Any further questions? Representative Litter.
Mr. Chairman, thank you. And back to the C paragraph 2, on another point, because I'm assuming we're trying to get at reduction of costs related to Title 25, right? That's also part of the work and the reason we're here and modifying this language. So by better defining who would refer that child, does that help also get to the point of trying to reduce our Title 25 costs?
Chairman Baldwin, Representative Flitner, so kids aren't necessarily maybe at one or two have gone through Title 25. It's a very, very small number of children. So the offsetted cost would likely, if this were successful, be likely on the Medicaid side with the psychiatric residential treatment facilities, that high level acute care, as well as potentially on the DFS side. So that's really there's an analog of those kind of savings in those areas, but not specifically in Title 25.
Okay, thank you.
Senator Sharp.
Thank you, Mr. Chairman. So what our discussion was earlier, if you remember, we talked about taking federal funds and what happens in the future. So there are various articles about the strings attached to ARPA. And so we're talking about moving ahead and paving a way so we can spend this money. Well, how do we know that we're not just pushing it along and attaching those strings to our state? So how, I mean, have we looked at this, at giving us a report so we can see where we're tied in and where we're gonna have an unfunded mandate and things that come along and things that are mandated? Because I think that's a big problem.
Mr. Chairman, Senator Bouchard, it's a good question. And the good news is that with this reform, this is largely a state general funded system with very little strings attached. And so that's why, again, some of the philosophical debates we're having is what's the best use of those funds for state priorities, because we can kind of design what makes sense for the state for the years and decades to come. There is a small amount, and I say small, relatively small amount of federal dollars in this system through block grants from SAMHSA, as Franz mentioned, as well as some Medicaid dollars that pay for mental health. But the vast majority of this line item budget for the Department of Health is state general funds and very customizable. With the ARPA funds that you mentioned, you're right. There's strings attached to those, and really more sideboards, as I was mentioning to Representative Flintner, of what types of expenditures are allowable, just like the CARES Act, which was very COVID related. ARPA is also COVID related, but a little bit broader in its allowable costs. That would be temporarily a potential solution to invest funds one time into this system that I don't think would come with those kinds of overly restrictive strings that I think were being discussed this morning.
Follow up. Go ahead, Senator. Thank you, Mr. Chair. And I'm hearing that there's a possibility. How do we know as legislators? Because I mean, we don't get that information. That stuff is all behind the iron curtain on your side, Kyle, and we don't get to see that. So I mean, I think we need to know that now. I mean, but what potential strings could we be tied into? You know, federal government says you're going to spend some of this money in mental health. What's permanent? You know, what can we walk away from? I think so. That's very important.
And Mr. Chairman, Senator Bouchard, very quickly, both the process for spending the state ARPA dollars, which we've also received a lot of direct ARPA dollars, as every other agency, not just Department of Health, has also received. I will say that the governor's process is extremely transparent, both with the public and with legislative leadership on where those dollars are proposed to be spent, and also audited and accounted for on when they're spent. So those reports are very easy to produce. On the direct ARPA funding side, same thing. So that is no problem on the fiscal end. We have to do it for our state auditor's office. We have to do it for the federal audit process. Everything that we've received through a federal grant from ARPA is totally discoverable, is public information. And as we move forward, we haven't spent a lot of those dollars yet, but as we do, we'd be more than happy to prepare those reports for the committee.
Further questions, committee? We got the proposed legislation, but before we hear that, I think we need to hear from the other folks that are in the audience. And for those who had the agenda that I asked you to tear up earlier, now burn it, please. We bought us an extra half hour, so we've got until 1:45. Yes, sir, Dr. Helena.
I guess thank you, Mr. Chairman. I guess along with the question that the senators was asking, I'd want to know, are we obligated to continue with these ARPA expenditures? Because ARPA is only going to be for another year or two. Are we obligated to continue with those expenditures with our state funds by accepting them now? Thank you, Mr. Chairman.
Mr. Chairman, Representative Hallinan, the short answer is no. And that's where the risk comes in of how we as a state, not we, Stephen Johansson, but we as a state decide to spend those funds. And so you'll see in the governor's plan and the priorities that he laid out for the legislature a month or two ago, one of the priorities is looking strictly at a criteria of being one-time investment, because we don't want to get into a situation where we have funded a system or a set of services or physical infrastructure that we now can't maintain going forward. So that is absolutely part of the decision-making process.
Thank you.
Thank you very much. Let's bring WAMSAC up here. While they're making their way up here, I would be remiss not to note the celebrity that came into the room during that presentation. If Representative Sweeney would please stand. Are you standing? He is standing. Welcome to our committee, Representative. We appreciate having your smiling face under the mask here. And we didn't have Representative Gray, but we must have bored him and he left. So thank you for coming to the committee. We'll return the favor. We'll come to yours. Yes, he used to love this committee, as a matter of fact. He's shaking his head. Yeah, he's a former member, so we value his input.
He told me last night he regrets leaving.
We'll invite him back next year. Okay, introduce yourselves and share what you have with us.
Thank you, Mr. Chairman. Andy Somerville, Executive Director for WAMSAC, and I'm accompanied today by Heath Steele, Chief Operating Officer for VOA. Appreciate you taking some time to hear some comments. I want to start by just saying that I think that Mr. Fuchs and Mr. Johansson undersold a little bit how much work has gone into this summer. There has been a tremendous amount of meetings. I think those of us that are attending all of them, were doing 3 or 4 a week at one point, and want to really just thank the Department of Health for all their work while they're continuing to manage a pandemic in the middle of all of this. So we really do appreciate that. I wanted to just start by kind of touching on a few things in the report. I think everybody should have a hard copy. You guys got this by email as well, but a hard copy of a letter and some tables that I'll refer to in a minute. I think it's really important. As you all know, I started this job about 2.5 years ago. You all received a copy of the WAMSAC history report that was dug out of the archives. And if anybody's curious, yes, there are some of those directors that are still around serving community mental health today. We might do some before and after shots after 30 years of service. But it's really important to kind of look at this history and really look at what's gone into it. The last time that really a major investment and major work was done with that by the legislature was in the 2005-2007 timeframe with another mental health select committee, trying to address some of the gaps. I think Mr. Fuchs did a great job going through a lot of the basics of the report, so I'm going to skip those pieces if that's all right with the committee, and talk about some of the points, some of the concerns that we have. So the first thing I want to talk about is the payment model. I apologize, I'll try to find the page number here. It would be on page 11. The payment model that's described in the report, from a provider's perspective, we don't actually think that that's quite accurate. We don't think it's malicious or anything along those lines. We think it's just a different interpretation. What's really important to point out about the outpatient and the residential payment model that we use right now is there already is some decent amount of risk placed on the providers. As it was described, those payments right now go out by the centers receive on the outpatient side a 30% base payment, which they receive every month, and then they have to draw down their contract dollars and service hours. There is risk in that if a center does not provide enough service hours, they certainly don't realize that revenue, and there is potential loss of base payment if hours are not delivered. And then on the residential side, it's a little different, but same idea applies in that they can risk their payments if they are not occupying those beds and providing those services. So that risk already exists for the providers. The second area that we wanted to talk about was really the solving problems section. So that starts on page 12. The providers disagree with the idea that the landscape has, we agree with the idea that it has changed, because it has since the 1950s and 60s, it certainly has. What we disagree with is that it has gotten significantly better to the point where we can potentially make major changes. Just in reference, the population of the state of Wyoming in 1950 was 290,000. So when we're looking at those provider graphs and those numbers that are going up, we might have kept pace with the number of providers that were back in 1950. I haven't done the analysis of that to be able to say for sure, but we are a health shortage area. We do not have enough mental health professionals in this state anywhere. From the bachelor's level to the master's level, psychologists. And if you can find a psychiatrist, please give us their number. We'd like to hire them. So we disagree strongly with that notion. along in this section of the report and those graphs that were shown about the number of providers, one of the things that we thought was really important to reference, and if you'll look at the back pages where the pie graphs start after the WAMSAC letter, it's like this. One of the things that we thought was really important to just kind of showcase was it's not the number of providers that are in an area, because mental health providers provide services to all the different kinds of people. There's a very long and large continuum from the private providers, community mental health centers, hospitals, RTCs, the state hospital, Life Resource Center, everybody is involved in the continuum. And so we wanted to just give you a really quick breakdown of where those people work. So on the legend for the charts, the CMHC is us. The orange is the private providers. School, I probably should have broken that down just a little bit more, but that includes school counselors, community college professors, and UW professors that are in mental health. Yellow is the state, and that includes anybody that works for DOC, DFS, or works as a contractor dedicated to a single agency, such as providing mental health services and substance abuse services in the prison system. The category select, that means that that provider works for an agency that has a very narrow focus, such as a domestic violence shelter or a residential treatment center for children or something along those lines, where it's not, you can just call up and see the provider. It's for a very specific subset of the population. And of course, hospital, federal, and then reservation for Fremont County is a category. What I really wanted to point out is that you can see that it varies greatly across the state. Not even the two biggest cities, Cheyenne and Casper, have the same makeup in terms of what types of providers there are in terms of who they are serving. You can see that, kind of as you get smaller in the communities, the community mental health centers make up a substantial portion of the providers that are in those areas. If you turn to the chart that has Worland and Evanston in it, Worland, 53%. And I assure you, that's not a big number of providers. If my memory serves me right, that's maybe 20 or 22 for the entire area providers. Most of those work for the community mental health center. And so we just wanted to point that out. We are still working on a lot of these conversations, including essential subsidy payments where the provider numbers for the statute and House Bill 38 really matter. But it's really not that simple. It's not just the number of providers that are in the areas. The next piece that I want to make some comments on is Title 25 and DOC tables that are found on page 17. To start with Title 25, this table is just a cross-reference of data of people that were seen by our centers on the state contract and people that have been through the state hospital. What this table does not show is the number of people that are diverted by community mental health centers today, right now. For the centers, we don't have very good data on that in the state of Wyoming. Some of the centers track it. Those that do, it's a pretty high number. It's 75 or 80% of people that are seen by a community mental health center, and that includes a community mental health center employee responding to a hospital, to an ER, to do a mental health evaluation. 75 to 80% of those people are diverted away from Title 25 into other services. And then on Table 6, Department of Corrections, as was referenced by the Department of Health, House Bill 31 that passed in the 2020 session, that is a major project that is still underway. We also disagree with the numbers that are in this table because it does not accurately reflect what comes in our door. We did substantial work with House Bill 31. We have providers across the state that in their SUD, their substance use disorder programs, their number of clients that are criminally justice involved are 80–90%. I think we had one last year we surveyed was 95% are criminal justice. And so there's a couple of things in that realm to consider. We don't know who's on parole and who's coming out to the community. That's something we're working on in House Bill 31 right now to open up those communication channels so that will improve and continue to grow. And the DOC parolees have choice. They don't have to come to a community mental health center. If they have access to a different type of provider, they are free to see them. There's no requirement that they come to us. And so just really want to put some context behind that data and make sure we're not painting a picture that's missing a few pieces to it. The next item that I want to address
We have a
is,
question.
oh, sorry.
Senator Sharp.
Mr. Chairman, I would like to know, when you talked about the percentage in criminal justice.
Mhm.
I'd like to see a breakdown of that in numbers of people, age groups. Of, that whole kind of demographic and what's happened over maybe the last 5 years. Just so we can see what's happening, because I think that's part of the whole recidivism question, is what we're doing working good? So that's just,
Mr. Chairman, Senator Bouchard, I'd be happy to get that information. We did quite a bit of analysis as well as CSG and DOC on their own. We can get that to you. So the next section that I want to comment on is in the recommendations section of the report under adults with severe mental illness. Starts on page 31. It is tier 1E. The working group had quite a bit of discussion revolving around, what focus are we really what's being given to the community mental health centers? What is the priority? And it is very clear from the House Bill 38 legislation, 38, yep, apologize, want to make sure I had the right bill, legislation, that one of the top priorities is for the community mental health centers to divert as many people as possible from entering the Title 25 system, and especially making it to that kind of third level of going to the state hospital. That's crystal clear to us. So we had a lot of discussion about, when do we get these people? When can we engage? Do they have to be sitting in the ER where a psychiatrist has already put them on a 72-hour hold, and then we can start treatment? The discussion in the working group was really, we need to get these people as soon as we can. And so the committee made a recommendation and I guess it's at the top of page 32, to add some language to that adults with severe mental illness definition, to say that they have a substantial probability of being unable to meet their need for food, shelter, and medical care. That's what's in the bill. And then adding, or are at risk of emergency detention. So giving us that ability to just engage with them a little earlier. And the comments that we saw back in the report, and as providers, we didn't have a conversation with the steering committee after they made this recommendation, was that they felt like that it might be blurry, and that there might be a different tier. Tiers 2 or 3 would be likely to catch these folks. We would be concerned about leaving this out. Again, it pushes us to, when can we engage? Tiers 2 and tiers 3 have a financial qualifier in statute of 150% of the poverty level. So we would have to, only people at 150% or below would be eligible to receive services. The second consideration is a lot of this has revolved around the fiscal ability of the state to support the system, this whole reform process. And the likelihood in a majority state general fund system of there being further budget cuts. As we all know, Wyoming seems to go like this all the time, and reducing funding in this model and how it's passed in statute in House Bill 38, we have tier 1, tier 2, and tier 3. If we don't have enough money, then we would expect you guys not to fund tier 3 or tier 2, and we would only have tier 1. So there's a possibility that those could disappear. And if you look at the money that's come into the community mental health system since 2013, it's decreased substantially. And if you had the data, which I'd be happy to provide, of funding going back even earlier into the early 2000s, we're not going up. The last major investment was made in the 2005-2006 years. And so that's concerning. If our primary mission for the community mental health centers is to divert people from Title 25, then we need to be able to get them before they get to that process. So we're asking you guys, asking the committee, when you take a look at that, to think about that and consider adding that to the draft bill.
Thank you, Mr. Chairman, and thank you, Ms. Somerville. Now I understand this a whole lot better than I when I was reading it. But I am curious about, again, the question I had asked about something else in relationship to understanding the notion of risk of, rather than, for example, under the previous recommendation, subject to Title 25, right? How do you assess a risk when I think of someone who's just subject to Title 25 because of it's an involuntary commitment? How do you do that? Can you do that?
Mr. Chairman, Representative Conley, so I have the COO here, and I'm going to pick on him a little bit because I really think what my providers tell me, it's a clinical judgment. It's when you see that person, when you consider their symptoms, it's a clinical judgment.
It has to be a clinical, sorry. Mr. Chairman, Representative, there has to be the allowance for a medical and clinical determination. There also has to be an allowance for a voluntary. I shared over lunch today, yesterday afternoon, we had a Wyoming citizen would have not qualified under the 150% that we're talking about here, but is not insured currently, but is employed, who decomped on us very quickly. However, she recognized the need for immediate acute engagement, yet we were unable to walk her through that process as a result of the multi-different factors in here. I'll be real simple about Title 25. We need voluntary and we need involuntary, and we need a system here in Wyoming that is election proof. And I have made this statement multiple times. We have 23 different counties doing it 23 different ways. And my gal yesterday wanted to kill somebody. And we were hung up in bureaucracy. We need to figure this out. Can you assess risk through a multitude of different risk tools and assessments? Yes. Is every one of them different? Absolutely. And we need to ensure that that clinical and medical component is the priority for admission. I have grave concerns in the world that we're living in right now in Wyoming. I'm 20 years into this job. I'm 20 years into this organization and many a nights out in the field. And I will tell you, this problem is not getting easier. And you compound COVID and you compound the Instagrams and the bullying and the challenges that our kids in the schools are up against. And it's not going to get easier. If we want to talk, the one thing we haven't talked about in reform here is we haven't talked about investment. I'm looking for the conversation that says not only do we reform a process, we invest in this process, because it's not going to get any easier. So I know I didn't answer your question directly about which tool, but rather we're using criminogenic risk assessment tools, whether we're using clinical assessment tools, whether we're using medical assessment tools. We have to, as the citizens of this state, find a process that allows folks immediate access regardless of all of the social ec tools that are in front of them right now to assess that.
Go ahead.
Thank you. So, thank you. So what I'm hearing though is what could have happened with the example that you just gave us is that therapist could have called law enforcement and said, this person is at risk to someone else, right? Law enforcement would then come pick up this person, take him to the hospital, where then another therapist would have to have done an assessment that you're talking about. By adding in this language, your argument is you would bypass all of those additional steps because that person would then be at risk of Title 25.
I am advocating that as we do any reform to that, we leave voluntary in it, because this individual was willing to go, which would have reduced expense to the state of Wyoming. And I'm advocating that we continue to figure out how to streamline it. Law enforcement was involved, clinical expert was involved, and the hospital were involved. We needed somebody to step up and say, no, we're going to keep her keys, and she's going to voluntarily get in the car and take a ride to the hospital. Would have solved the whole issue.
Mr. Chairman, one more follow-up. And this is, you're probably the wrong people to ask this, but why did the steering committee not concur?
Mr. Chairman, Representative Conley, all I can go by is what was in the report, which is that they thought it was a little squishy, created some gray area, and that it might be covered somewhere else. I believe there was a third reason, but I would defer to the steering committee.
Might not have qualified.
Mr. Chairman, just a couple of other quick things to touch on. During the Wyoming Department of Health presentation, there was some discussion about the outcomes section, which is of concern to WAMSAC providers, as you well imagine. We talked a little bit already about the risk that's already in the system and how we contract it. There has been some discussion, but we're pretty far away from that. But we do have concerns about the general idea and concern is that the community mental health system can fix all the woes of society. And as the example, I think during the previous conversation about aging, when asked if the hospital should be going to all of these people's houses, My answer to that is the same, and that it's a system of care. Everybody has to participate, and that the community mental health centers can't solely fix somebody that has a mental health disorder to make sure that they have housing and employment. We already provide services at our centers to connect them with services and try to help them with those things. Because at the end of the day, outcomes are for this person's mental health condition, schizophrenia. Did their daily activities increase? Did their life enjoyment increase? Are they more stable? Did they get to go out and do something today? For somebody with that type of disorder, that's improvement. That's an outcome. And we measure those currently right now in our state, in the state contracts for the community mental health centers. So we want to keep an eye on that. We certainly had a lot of conversations with CSG when they were here in 2020 about what appropriate outcomes are attached to dealing with criminal justice population. We want to make sure that we get down to that fine-tuned detail. And we do agree with Mr. Fuchs in that there's a lot of information we'd like to have in Wyoming about outcomes. And there's a lot of stuff that's of interest, not just to them, but to us in general. But whether we tie a payment to that, require a provider to hit that is a concern. We also want to make sure that we're not creating two systems where the big centers, of which we have 3 at the moment, can provide all these more resources and they get better service. And then the rural and the frontier centers that are smaller, that don't have those resources, can't do that. That maybe they can't have somebody on staff that's fully dedicated to housing or workforce programs, and they have to do that in a different way. So we want to be careful about that, and we're concerned, but we're keeping an eye on that. The last thing that I want to touch on is the recommendation to delay the implementation. We've had a lot of great conversations. We wholeheartedly agree that it needs to be delayed. So just so the committee has the lay of the land, there are a lot of things going on in the community mental health world. Not only are we still serving in the middle of a pandemic, which has ravaged our residential treatment centers. It's very difficult to keep COVID-19 out of a residential treatment facility. We are seeing immense burnout amongst our mental health providers. They are leaving the field in troves. They're done. And we are very much struggling to replace them. And it's not just us, it's all mental health professionals across the state. Due to the budget cuts, it's kind of death by a million cuts to the community mental health center. We had Medicaid reductions. There were some step 2 and then step 3s that were implemented. Plus, a lot of our community mental health centers took additional budget cuts from cities and counties because the cities and counties could no longer support that program because of their budget cuts. Our centers are under tremendous financial strain. Many of them are dipping into savings to make their payroll. And so what's happening because of that is our own little reform process within the system is these centers are figuring out what they have to do to make sure that they're still there tomorrow and can provide services. Operating Officer Steele just finished a merger for VOA to acquire Peak Wellness. It's a huge deal, and it took 9 months, and it's been finalized for about 40 days. Yep. We have another one that will probably close in about a month, and we have 5 more of the individual centers that are looking at what they need to do and how they need to band together to make sure that they can still provide services and cover all 23 counties. What I can't sit here and tell you today is what the landscape will look like 12 months from now. I can't. I don't know who will be here, what center that will be, how big they'll be, what services they can provide. We don't have that information. In addition, we are working on a project with the Wyoming Department of Health Behavioral Health Division to do a gap analysis for behavioral health, focusing a lot on crisis services, costing some studies that need to be done, that data will be available later this fall. So what I'm trying to say is there's a lot of things going on, plus House Bill 31, criminal justice implementation and changes. There's a tremendous amount of things going on. And what we want to make sure we do with this is that we vet it and we have it figured out. And there's so much detail that we don't have about the eligibility process outcomes, not to mention going through the rulemaking process with DOH and moving this system. If we try to do it too quickly, then we'll have to be back. And I know how much the committee loves hearing from me on a regular basis. But we want to make sure that we do it right. As tradition dictates, in December or January, the Wyoming Department of Health will release an RFP to re-up the contracts for the community mental health centers in December and January of 21, sometime in that timeframe. Traditionally, those are 2-year contracts. What we're asking for is some time to not only continue to work out the process, but to complete that next 2-year contract cycle and ask this effective date to be moved to July 1 of 2024. Now, hearing the discussion that I've already heard, I think that it's appropriate to put some sideboards on that, some check-ins, however we need to do that in the request so that we make sure that we're moving on track, because we certainly don't want this to fall down as a low priority. And then all of a sudden, here comes the end of 22, early 23. Oh my gosh, hurry up, let's run and get it done. That's not what we want to do. So with that, I would turn it over to Mr. Steele.
Chairman Committee, I want to say that this has been a good process. I've been involved with system for 20 years, and this is probably the healthiest and the most discussion and the most participation that I've had the pleasure of being engaged with. So I think we're headed in the right direction, and I want you to hear that. Make no mistake about it, and Andy touched on it. I'm going to hit it hard for a minute. We're in the middle of a war in our residential treatment programs with COVID. I'm down here today, but I have staff home with 17 positive clients. Those clients are court ordered. Those clients are placed. Those clients have nowhere to go. They can't walk away. They're under court order. We have to maintain them. I am renting, I guess the only gift in the oil and gas crisis in Wyoming is I'm able to rent those trailers to use for quarantine right now. I've got 38 open positions today. I am paying well above the average in Wyoming for any of those positions, and looking at regional and national wage calculators. I'm paying a $5,000 sign-on bonus right now for a newly licensed clinician. I am paying bonuses at every position. I am asking people to drive COVID positive clients up to the hospital to get infusions that are behavioral health techs on the front line. I'm not complaining about it. I need you to know where we're at. We did not close our door. We as a provider exceeded the deliverables in our contract, the BOA's contract last year, and we stayed as your safety net. We're going to stay as the safety net, but I need you to know where we're at as a legislature. I'm struggling a little bit right now because what do we need to bring into Wyoming to help with this COVID issue? I listened to all the testimony this morning. I'm married to a nurse. I have a daughter graduating from UW in the nursing program. We can't do presentations and talk about Obamacare and talk about insurance and talk about access to it, solving our mental health issues if we're not willing to look at the other resources, and vice versa. We can't do reform based on the back of that either. I had 378 residential clients last year. I billed a little over $2,700 in insurance. There has been no discussion of how we're going to manage residential in Wyoming. There's been no discussion of how we're going to pay for it. We had one day of payment discussion in Rawlins, Wyoming. It was 4 hours. I really appreciate all the work that the Department of Health did to bring that forward in Rawlins in August. But 4 hours is not going to lead a payment reform process of how we pay providers. I'm advocating for 24. I recognize that there's could possibly be turnover. This committee could be turnover of me. I don't know. That's something I'll have to wrestle with as we continue to fight through this pandemic. What I will tell you is we're not ready for this. We're on our way. Franz and Director Johansson and Director Shannon, Director Schmidt have been leaders, and they have helped walk this process forward. But we are less than 4 hours in payment discussion, and we drove to Rawlins to have it. I'm grateful everybody's willing to meet in person. I do want to advocate one other thing on the residential side, and this has been a message of mine for a very long time. These residential facilities that are in Wyoming are a gift. They're a gift to the Daniels Fund. They're a gift to the communities, the McMurrays, the families that have stepped up, the Marses, and built these residential facilities. These programs do not, those facilities do not belong to the state. They're there as a gift that we have to steward. And in stewarding those, we need to understand how we're going to utilize them. Right now, I'm over 90% on paper criminally engaged individuals in my facilities. My waiting lists are months out, months out. Now, as Andy shared, we acquired Peak Wellness down in Cheyenne. It's no secret, Peak had a lot of challenges, both leadership and operations, but they also had 66 years of history. You know what wasn't down there? A single bed in southeastern Wyoming for a female. I am hauling, if you're a female and you live in Laramie County, Albany County, Goshen County, Platte County, I've got to drive you to Sheridan to go to treatment right now. As we think about this system, we have to determine where our assets are needed. Andy talked a little bit about what we're going through right now, and I've been very vocal with the director's office. I've been very vocal with the legislators involved. We're walking through this review process that DOH has brought to life, and I think it's a good one with MTM, and we're studying gaps, and we're studying costs, and we're studying service delivery, and we're studying crisis. And the providers are carrying that work right now. I'm 18 hours of meetings in the month of August into that, on top of trying to serve what's going to be around 3,000 clients this month. We need that data. We can't use anecdotal data to make these decisions. We can't. We need to understand where's the gap, where's the service need, and what does it cost? You know, I'm a little excited about this cost survey. I'm going to wrap it up here, but I saw some numbers the other day, and I think I'm charging you as a state about $250 a day less than I should be. So I'm kind of excited about this process to have a conversation around what that break-even number looks like. But more importantly, I think we need to stay in the process and allow this process to happen. And we need to make sure the right players are at the table. We haven't had a vocational discussion. I mean, I can measure outcomes right now in GAF and DLA 20 and look at some recidivism, and I can use all kinds of risk assessment tools to determine where to put somebody. The conversation we haven't had is if outcomes are employment and school and graduation, and we can court order sobriety, but you can't ask for recovery. And those are two different conversations. We need to be able to get through some of this process. I am very excited and committed to be at the front and working with these guys on this. And I think as providers, we have an obligation to, but we're not ready for 2023. Not right now.
With that, Mr. Chairman, we stand for questions.
Questions? Committee, are you wide awake? No questions.
Mr. Chairman, I don't know how that's possible, but I guess we should run away quickly.
Don't expect it every time.
Thank you.
Thank you for.
Thank you. Is there further public comment on this? Come on up. Welcome to Labor and Health.
Thank you. That seems to help. We have a large gathering of mentally ill within our facilities. We have chronic and severely mentally ill units. We don't have the luxury to go to the state hospital or Title 25. We have to deal with what we take place there. Comment regarding graph 4. As Andy Somerville commented, I do believe it's distorted a little bit. And my reason for it, we release a small percentage of individuals into our community, but we also have over 7,000 under supervision. The Department of Corrections does have a high rate of return, or recidivism rate under supervision, and we're working diligently on it. We have a long way to go. What are we doing? Several things. We're revamping the way we're doing business as far as from a risk management supervision. We are very thankful for the legislators who provided Title 31. Our rate of return, which has been affected by COVID, has dropped considerably since then. I've changed the way we're doing reentry. We moved them back in the institutions. I recently received a grant to have National Institute of Corrections review our reentry, and how that'll take effect is those reentry workers, which are 9 of them, will ensure that our mental health community providers, that it's a fluent transition. So we have a long way to go. We certainly have quite a few mentally ill individuals, and Senator Hutchison, if they're in there for 5-6 years, normally the whole time they're receiving treatment, but it carries on throughout. It's those 7,000 other individuals that we're also responsible for, that we have to ensure we're providing treatment, or at least trying to get them to treatment is very challenging, and we accept a lot of responsibility. We have a long way to go. Mr. Chairman, Madam Chair, I stand for questions.
Questions, committee? Go ahead, Representative Bachman.
Mr. Chairman, thank you. And this is a question, I hope it's appropriate. When one of your detainees or prisoners, when they are released, a lot of the talk today has been about mental health, and a lot of these people have broken every tie that they have with family, friends. They may be from a different part of the state or a different state. When they're released, how does that work? I mean, where do we know where they go, or do we do anything, or do we keep up with them? I mean, I know there's usually probation, but where do these people live? I mean, how do they get anywhere?
Director.
Thank you.
Mr. Chairman, Representative Ottman, I think the question is very suitable, and it's very realistic. Majority of the times, the parole board will release them to halfway houses through our ACCs and things of that nature, so they have supervision. We actually have, as I mentioned earlier, a reentry team that works with our community providers, it works with employers, it works with so many volunteer and community agencies that are trying to provide housing. And there is a small percentage that I would anticipate, 3 to 4% anecdotally, that do leave our state or they drift. It's more especially if the courts determine they're not under supervision, where we don't have some form. It's not oversight to discipline or control, it's oversight to support. So.
Go ahead, Representative.
With the problem of funding or whatever, and we're seeing with residential healthcare and halfway houses and stuff, because I know not every community is able to support that need. What is there in the state that really steps up and is able to do that?
Mr. Chairman, Representative Ottman, we have three halfway houses that the Department of Corrections utilizes within our state, located in Gillette, Casper, and Cheyenne. So we will transport, or the community correction centers, similar to what testified today. I can clearly say that they'll also transport and provide to get them there. We have to take the individuals to the centers. We can't rely on them, putting them on a bus and get them. That doesn't work.
For the questions committee, I see we're clear down on the end. Senator Hutchins.
Dr. Shannon, thank you. You haven't been doing this long, right? It's been like 5 years, maybe?
I graduated the academy in 1985,
No.
36 years.
No, I mean, you were.
Oh, the director?
Yes, sir.
Mr. Chairman, Senator Hutchison, I became the director in July of 20.
Gotcha. Just a quick follow-up, and I do appreciate you answering that question, so that will lead to another question.
Sure.
What do you see as the reason why our young men are going to jail? And then their return rate, what's going on there? Are they seeing that society isn't the way they thought it would be? They'd rather be in jail, or they're just, is it the mental state and they just don't know how to really control themselves?
Mr. Chairman, Senator Hutchins, it's a wide array. I'm certainly not dodging the
Right.
question. It's a wide array. The center, majority of the rate of return to our institutions or revocations or mentally ill and drug and alcohol addictions. That's really what's driving more.
Thanks.
Through, if I may, through my years, the community certainly are stepping up. And I believe correction centers as a whole stopped living in a vacuum and came out and said, we need help. We are the community. So I know that it may not answer your question. But I would say it's drug and alcohol as well as mental health related.
Representative Conley.
Thank you, Mr. Chairman. Director Shannon, I bet you love this bill, the original bill. I mean, honestly, it prioritizes justice involved individuals getting tier 1 services. But for me, with thinking about this bill last year, I was more interested honestly in doing prevention to stop in some ways justice investment, justice involvement, and not needing to worry about recidivism. But one of the things that concerns me is that I believe that we in the legislature have cut programming in the prisons that would address issues like mental health and substance abuse programs, and that honestly that you have seen recidivism increase over even the past 5 years. And I'm curious if you could provide us some of that data and in relationship to the programs that were cut and who you're seeing coming back again. Because honestly, pushing out to the communities after someone's been in prison, honestly, if we could take care of it in prison, they wouldn't need to be seeing folks. If we prevented, we had opportunities for people so they didn't end up in prison, that would be the beginning in my mind. So could you give us some of the data on what has happened in the past 5 years?
Director.
Mr. Chairman, Representative Conley, just a few things. Absolutely, I'll provide that data to you. 5 years ago, when we did make a cut under the Meade administration, we've seen our recidivism rates grow by 8%. The legislators have changed it. The Department of Corrections took one heck of a hit. We took $28 million, but I, as the director, chose not to cut any programming within the facilities. I chose not to do it, but with that cut, we certainly, our vacancies, our staffing, we're really hurting. We did reduce some of our ACCs. And also with that, the majority of the revocations that we're seeing is not from previously incarcerated individuals, it's from probationers. So it's individuals outside the community that are being returned who have never been to prison, are now being sent to prison. So you are correct. I smiled pretty big when I seen that we actually had a piece of legislation that said, let's invest our money on those that are costing the most. Thank you for your time. I'll get you the information.
Further questions, committee? Representative Ottman.
Mr. Chairman, just a quick question. Is there any correlation between the rates of probation violation and a possible shortage of probation officers?
Mr. Chairman, Representative Ottman, I believe it's certainly a contributing factor. At the current time, we're actually reevaluating every position that becomes vacant and reassign it to the district because of the overwhelming amount of supervision per agent. But we're no different than the other state. It's the same everywhere.
Thank you. Thank you very much, Director.
Thank you. Thank you, committee members.
Is there any further public testimony? The celebrity in the room approaches. Welcome, Representative.
Thank you, Mr. Chairman and committee. So I think one of the last things we want to do is destroy our system with our counseling centers, independent providers in the smaller communities. And Senator Burchard and I worked with within the prison system, trying to do some different things on licensing to try to help the situation as far as getting people employed, trying to direct more to the prisons. Ultimately failed in the House, but I think this delay really should be looked at by the committee. And I don't know if a full year or what the magic moment might be. But we've got to wrap our heads around this. And so if a year delay will help on the implementation and give us better information, better data, I think it's worth considering. So thank you, Mr. Chairman.
Representatives, questions, Senator Bouchard.
Thank you, Mr. Chairman. I will tell you there's good news. I've been told by people on the other side that what the work that we together we worked on for 3 years. We finally got pieces put in. A little birdie told me they just had to take mine and your name off of it, which is done through committee. So that's the bright side. I think so. There's some things happening there, and then so we give them the tools to work with. So, and I want to thank you for your work for that too.
Further questions, committee? Thank you, Representative. Thank you for being here today. Well, you're welcome back in our committee anytime you want to come back. Any further public testimony? With that, we'll close public testimony on this committee. We have a decision to make. You have proposed legislation before you. We have several options. One of those options is somebody could move this. We could work it. Another option is we could table this one and talk about it in November. But I will leave that at the committee's discretion and recommendations if anybody has a recommendation or a motion. Representative Sever.
I move we table it and talk about it in November.
We have movement. Any discussion? Chairman Wilson.
Oh, I'm not sure it's discussable.
Okay,
I'll second that.
motion is seconded. Is there any further discussion on this?
Mr. Chairman,
Yes, ma'am.
if I could just ask the bringer of the motion, his preference to deferring it.
I think needs to be a little more work. I've heard a year and then 2 years, delay it for 2 years. I'm preferring to delay it for 2 years. I voted no on House Bill 38. I did not like that bill. And I delaying it 2 years for the contract extension and these guys to get more work done on it, to make sure this is right before we implement it, is the best way.
But Mr. Chairman, if I may,
Go ahead,
I'm just
Representative.
curious, why wait till November? Why not go ahead and move the legislation today and then we can discuss it and work the bill in November? That's just my question.
Further discussion. Chairman.
Thank you, Mr. Chairman. So I'll just say to flesh that out personally, I'm okay with tabling it to November, but I support the proposed legislation as is. I think it's fine. I just fear that we can't possibly, I'm sure there's going to be some talking about it. And we're already, that would make us at least an hour late to WBI, which I think we should be respectful of their expectation that we're going to show up and get a tour. So my preference is to just to table it for November with the thought that we will take it up. I think it's good, but I just don't think we can deal with it properly this afternoon, that having spent so much time on other things earlier in the day.
It's the chairman's fault.
No,
Further discussion. Otherwise, there's a motion and a second on the floor. Question's been called. All in favor of tabling this until November, please say aye.
I,
All opposed? No. That motion passes. We will be hearing this again in November. We'll put that on the agenda. With that in mind, we are going to end today's
Mr.
meeting.
Chairman, can I just ask a quick question? I
Sure.
just want to clarify in terms of moving this forward. I mentioned I have several amendments that I'd like us to consider going forward. Would it be okay if I kind of gave those to LSO now as amendments? So that
Absolutely.
the committee
Get
could
them prepared.
get them prepared ahead of time? Okay, thank you.
Absolutely. One
And-
more, no, oh, go ahead.
I was
Chairman.
just gonna say, and maybe we could actually ask LSO to draft up the proposal in an LSO form so that when we refer to it, we've got page numbers and line numbers, I think would be
Right.
helpful in the discussion.
So noted. One more further thing that I would note is we've been notified by WBI that there is a COVID case there. So it may alter our tour somewhat. We may not see everything that we were going to see. Can I get a show of hands on how many people are going to WBI off the committee? Okay, so a little over half. Very good. Well, we will adjourn from here today. I would also suggest, since we've got a couple of things, that we start at 8 o'clock instead of 8:30, but that's up to the chairman for tomorrow.
We do that with it having been posted.
Excuse me, it's posted at 8:30.
I know, can we change it at this late? Can we change it at this late date if we post it at 8:30 to start early? Attorney LSO?
Mr. Chairman, Madam Co-Chairman, it's really the chairman's prerogative. It is rather late in the day, so I don't know if the notice would be as good as it could be, but it's certainly your agenda and you can approach it as you wish.
I think we should just start at 8:30.
Okay,
I don't want people to,
a command decision.
Miss something.
8:30 it is,
but promptly.
said the chairman. Okay, anybody got the directions that was in your email to WBI? Where did security go? Is this room secure? Does anybody know?
I don't know, I'm taking.
Is the room secure?